The gut is often referred to as the body's second brain, influencing everything from digestion and immunity to mood and energy levels. Gut Check, understanding your gastrointestinal health. Tonight, on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Jill Kruse, your volunteer Prairie Doc for this evening's program. Tonight, we are discussing your GI health and answering your questions throughout the show. Good gastrointestinal, or GI health, is crucial for overall well-being as it directly impacts digestion, nutrient absorption, and energy levels. When our GI system functions properly, we experience less discomfort, reduced bloating, and improved mood. Conversely, issues like constipation, indigestion, or IBS can lead to chronic discomfort and may affect our daily activities and productivity. In the studio this evening are Dr. R. Towner Lapp from Avera Medical Group Gastroenterology and Dr. Jeffrey Murray from Sanford USD Medical Center. Thank you both for being here with us tonight. Dr. Lapp, could you please share a little bit about your background and what brought you to this field?
I'm from South Dakota. I grew up in Sioux Falls. I got an early interest in gastroenterology with Dr. Murray here, knowing him for a long time. Always been interested in a scientific field, and once I chose medicine as my general residency, gastroenterology spoke to me due to the multiple facets of patient care you can entertain with in the clinic, with procedures in the hospital. So there's multiple aspects that drew me to gastroenterology.
Wonderful. And Dr. Murray, we'd love to hear a little bit about your journey.
So my journey began years ago, and I was initially interested in gastroenterology because, as a first or second year med student, because I knew that our gut protected us from so many foreign antigens or foreign substances, from our diet, from anything else. And I just thought that was totally fascinating. So I was always interested in gastroenterology even before I did a clinical rotation in gastroenterology. So I just knew that that was the place that I wanted to be, and it was a good choice.
Wonderful. Well, before we get into our discussion, I just want to pause and express my gratitude for all of our viewers. Each dollar you contribute goes a long way in helping us create meaningful content that guides individuals in making informed health decisions. Now let's turn our focus to you, our audience. We invite you to submit your questions for tonight's conversation on gastrointestinal health. There are 3 ways to reach us. Call us at 1-888-376-6225, send an email to ask@prairiedoc.org, or engage with us on our Prairie Doc Facebook page. We will do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions are anonymous and no information will be saved. However, if you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. But it is not a requirement to submit a question. We'll announce the winner at the end of the program. Well, let's get started. We already have several emails that viewers have sent in and Facebook questions that they sent in before the show even started. So that just tells me that there is a lot of questions and a lot of need for us to do this topic. So we'll get started here at the top. A viewer says that they feel full very quickly and also are experiencing bloating. Are there specific issues they should ask their doctor to investigate? Dr. Murray, if someone said that to you, what would you start looking for or ask about?
Bloating is a very common symptom in gastroenterology. It's a common symptom expressed by our patients. And a couple of things you always have to think about with bloating. Number one, is it a motility issue with the stomach? We do see that often in individuals, especially now with the advent of GLP-1 agonists, which is a new medication, and that will slow the stomach down. So oftentimes they'll become bloated on that medication. The other symptom that I always ask my patients about if they're bloated is if they're constipated, because they go hand in hand. And if you can alleviate somebody's constipation, you can oftentimes help them with their bloating. And I'm not talking about using fiber supplements, because oftentimes that can make it worse. There are other medications out there that will help with constipation. So the two things that I would always think about in somebody that's bloated is it a problem with the stomach motility? Is it slower than it should be? We have a name for that. It's called gastroparesis. And that's something that we can do something about. Or if there's constipation, we can do something about that. Other than that, then you have to start thinking about some other things like celiac disease or gluten sensitivity. Those are items, and you can even get into some esoteric things in gastroenterology that sometimes requires testing with the upper scope and maybe the colonoscope as well.
All right, well, we'll keep going on to questions because several are coming in. Dr. Lapp, a viewer says their stool test for common infections was negative, but they're having chronic diarrhea. What would the next step, and what could be causing a chronic diarrhea that's just not letting up?
So again, that can be a complex topic to tackle, and infections are just one source of chronic diarrhea. So if they've taken care of the chronic infection process, then there's a lot of other processes that may be at play. Are we absorbing things that we're taking in correctly? Are there anything that is increasing the speed in our GI tract? Other testing besides just stool tests for infections may require some laboratory evaluation, may require a upper or a lower scope or a colonoscopy to do mucosal biopsies to further delineate a source of that chronic diarrhea. But again, a stool panel for infection is only one part of the workup, and that workup can expand based on what you find with your initial evaluation.
All right. Well, next question is, a viewer said they had their gallbladder removed 8 years ago, and since that time has used an H2 blocker every day. Is their current dose of antacid or H2 blocker masking a more serious issue? And at what point should they stop relying on over-the-counter treatment? They say that if they don't use it, they end up with heartburn. Can they be on this long term? I know all these things used to be prescription, but now they're over the counter. That definitely affects. It's very easy to be on something long term when you just go to Walmart and buy it.
Mm-hmm. So I agree that H2 blockers is one treatment for reflux, and taking out the gallbladder probably didn't make the reflux worse. It was probably the fact that they had reflux most of the time, and maybe it was unmasked after the gallbladder was taken out. There's a couple of problems with H2 blockers. We're talking about famotidine, Zantac, Tagamet, some of those. They have something associated with them called tachyphylaxis, which means after a while the medications don't work. And usually it's about 8 to 12 weeks, and so that was why proton pump inhibitors are used now most commonly for reflux. And there have been a lot of studies done with proton pump inhibitors in terms of long-term side effects. It turns out that most of them were probably inaccurate. And so if somebody has reflux and they need to be on a medication, it's okay to take it. But I think sooner or later, anybody that has reflux long-term has to have an upper endoscopy to make sure that they don't have something called Barrett's, which is a precancerous change in the esophagus. And that's managed in a different way sometimes, but all the time it's managed by making sure that they don't have reflux. So my comment to that would be maybe they should switch to a different medication, like a proton pump inhibitor, to probably have better control of their reflux. H2 blockers are cheap, and it's hard not to take them, but after a while they probably don't work as well.
Mm-hmm. And a lot of the proton pump inhibitors are also over the counter now as well.
A lot of them are over the counter now as well, and Prilosec is over the counter, Prevacid is over the counter, and they're very good drugs. And there's really no problem with being on them long term. I think there are a couple of studies that implied an intestinal infection risk, but the whole osteoporosis, kidney problem, dementia problem, turns out not to be a significant situation.
Okay, good. Well, another viewer says that they have been keeping a food diary and it suggests a specific trigger. Is that a true food intolerance, or could that be a symptom of something more complex like irritable bowel? So someone obviously has a GI issue if they're keeping a food diary. Can you explain what a food diary is and why someone would use it? And then,
yeah, I think with food diaries, and it depends on which specific symptom this patient is referring to, but a food diary is trying essentially to look backwards on what you've been taking in, and can you find a trigger that is exacerbating your underlying GI symptom that you have. Now, irritable bowel syndrome's a complex syndrome that affects many people in this country, and that's a whole nother topic of conversation. But yes, there are specific foods that may exacerbate your underlying irritable bowel syndrome if that is in fact present. There are certain foods that are not a true allergy. You know, I think one of the big foods that we talk about are gluten-containing foods if you have celiac disease, and making sure that's not causing some of these symptoms. But yeah, a food diary can be essential to help narrow down certain trigger foods which may exacerbate your underlying GI condition.
okay, all right. Well, another viewer saying that they've been having trouble with stomach problems and swallowing issues for quite a while. They went to the doctor and had an ultrasound on the gallbladder and on the throat. Didn't show anything other than a hiatal hernia. So they had a HIDA scan ordered that showed the gallbladder was only functioning at 8%. They said the surgeon didn't seem really concerned, said it may help, it may not to take out the gallbladder. What are your thoughts?
So I'm assuming most of the problem here is with swallowing. And you know, taking out the gallbladder probably won't improve that. And it sounds like they may have had an upper endoscopy as well. Dr. Kruse, is that possible?
Possible.
I couldn't tell for sure there. I know they had the ultrasound, but to find a hiatal hernia would almost imply that they would have to have had an upper endoscopy. And problems with swallowing can be, it can be several. And you can have a normal upper endoscopy and still have a motility issue with the esophagus, and that would require a separate test called an esophageal manometry, or some people call it a high-resolution manometry, and it looks at the motility of the esophagus. Most of the time, if they had a normal upper endoscopy and had a hiatal hernia, most of the time that can be controlled by controlling reflux. If we control reflux, if they're having reflux, their swallowing problem will improve. But it sounds like the next test they need is probably a high-resolution esophageal manometry. The other thing is that they probably, hopefully, had random biopsies of the esophagus, because sometimes we can find microscopic changes in the wall of the esophagus that can cause problems with swallowing. There's an entity out there called eosinophilic esophagitis that sometimes, where the esophagus actually looks normal, but under the microscope we see changes of that, and that can be successfully treated as well. So there's probably a few more tests there that they need to have done.
All right, so don't give up yet. There's still more information
Never
to get.
give up.
All right. Well, the next viewer says, if you don't have heartburn, what could be causing the chronic cough or hoarseness?
Oh, that's a good question. That's something we see in the clinic quite frequently. So if a patient does not have overt heartburn or burning in their chest or regurgitation, they may still have heartburn or underlying acid reflux or gastroesophageal reflux disease as a source of an underlying cough. Typically, to investigate if reflux is causing an underlying cough, it requires an upper endoscopy to say, hey, is there a structural abnormality? Do you have findings suggesting of underlying acid reflux? In addition, a pH study, whether that is a wireless capsule or a catheter we place into the esophagus to measure acid. That's a little bit more of an objective test that can correlate symptoms with actual reflux episodes. So it sounds like they may need another test or two to narrow that down, but it still can be reflux causing their cough, even though they don't have the overt or classic heartburn.
Yes, the silent reflux that we
Yes.
talk about. Yep. All right. Well, we'll just keep going with questions because they keep coming in. Another viewer said they were diagnosed with an ulcer and are being treated. Is this something that can come back after treatment?
It depends on the location of the ulcer. If the location was in the stomach, or what we call a gastric ulcer, that usually necessitates a follow-up endoscopy to be certain that the gastric ulcer has healed completely, because rarely those situations can be precancerous or even become cancer. So it behooves that patient to be certain that they have a follow-up endoscopy if the ulcer is in the stomach, to make sure that it's completely healed. And oftentimes, if they have what we call dyspepsia, which is a type of ulcer type symptom, or they have concomitant reflux, sometimes they do need to be on a long-term ulcer medication, which quite frankly is the same thing as an anti-reflux medication, as a heartburn medication. If the ulcer is present in another area of the upper gut, like the duodenum, that does not require a follow-up endoscopy, and usually just a short course, 8 to 12 weeks of an ulcer medication will handle that.
Okay. And common causes of these ulcers, is there things people are doing that could cause that, or in the future? Well,
that's interesting. I mean, it used to be that I hate to pick on Advil, Motrin, ibuprofen, but those are very common causes of ulcers. We live in South Dakota, and there's a bacteria in rural South Dakota called Helicobacter pylori, which is indeed associated with ulcers, and biopsies need to be taken at the time of an upper endoscopy to be sure that they don't have that bacteria, because it's important, because that is a common cause of gastric cancer. So if they have an ulcer and they have an upper endoscopy, I'm assuming that they will have had biopsies to be certain that they don't have that bacteria, which needs to be treated.
All right. Well, Dr. Lapp, another viewer says, can we talk about hemorrhoids? My husband was diagnosed with them and surgery was recommended. So,
very common problem that we see in office, or when we do a colonoscopy or a digital rectal exam. And those hemorrhoids can range from it's irritated, I feel something when I wipe, or they may bleed. They can be quite painful at times. Certain times they can respond to a bowel regimen, softening the stool, giving more topical treatments, sitz baths to try and calm down some of the inflammation. Other times, if they progress to the point where they're bleeding quite extensively or causing quite a bit of pain, yes, then a surgery may be indicated to ban them or actually remove them.
Okay, all right. Well, Dr. Andrew Paul Deeb, a colorectal surgeon at the Surgical Institute of South Dakota, recently discussed with the Prairie Doc how gastrointestinal issues significantly contribute to the development and worsening of hemorrhoids, which are swollen veins in the lower rectum that normally aid incontinence.
First thing I tell patients is that hemorrhoids are actually normal. Everyone has them and they serve a good purpose. The issue is that they become abnormal over time. Hemorrhoids are broken into internal and external hemorrhoids. Internal hemorrhoids on the inside of the anal canal. They're essentially excess tissue or cushions that provide aid in continence. And then external hemorrhoids are on the outside of the anus and essentially are a vein plexus, or a series of veins that help drain the anus.
Dr. Deeb explains symptoms vary by patient.
They cause most commonly bleeding, pain, and/or protrusion of tissue, and it's a little bit dependent on which part of the hemorrhoid complex is involved. Internal hemorrhoids are most commonly involved with bleeding, and that's typically painless bleeding, and also potentially the protrusion of prolapse of tissue. External hemorrhoids are primarily involved with pain, some local irritation of the skin, and can also cause blood clotting and/or a painful nodule or skin tags over time. And oftentimes, the series of symptoms intermix because most patients have a component of both internal and external hemorrhoids.
Gastrointestinal issues can affect hemorrhoids.
The vast majority of anal rectal symptoms, by and far, and hemorrhoids being a very common one, or one of the most common, is secondary to abnormalities or suboptimal bowel movements. And so it's really principally driven by bowel movements that are either too firm, too hard, and constipation or straining, and or too loose with diarrhea. So GI problems in that regard with abnormal bowel movements contribute and or cause hemorrhoids to be exacerbated.
Some behaviors, like spending extended periods of time straining, can also contribute to the problem.
One of the driving factors as a result of constipation or straining is that you're increasing the pressure within the anus and the rectum. And as we mentioned, those hemorrhoids are very vascular, and so both by method of shear forces or mechanical straining, putting pressure, and then subsequent excoriation or breakdown of the tissue, it causes stretching out, laxity of those tissues, and then breakdown of those blood vessels and bleeding. So things like hard stools and constipation, diarrhea even, because there's a lot of straining associated with that, but even things as simple as prolonged toilet time. I always counsel my patients 5 minutes or less on the toilet. If you haven't been able to evacuate in that time period, you should get up, walk away, and come back, because it's that position that also contributes to increased pressure and exacerbation of both internal and external hemorrhoids.
Well, can hemorrhoids affect more than just the GI health?
I think, you have to be careful when you do surgery on hemorrhoids, because you could have a problem with incontinence. And so that's something that you want to avoid. I think, as Dr. Lapp suggested, banding hemorrhoids is probably fairly innocuous and is probably not going to lead to that. But that's always the risk that you take, is when you're operating on either external or internal hemorrhoids, you want to be certain that you don't disrupt that sphincter to be sure that they don't have fecal incontinence. So that would be the main concern.
All right. Well, another viewer says that they are taking Ozempic and have been having some GI issues. Is there anything they can do to help with the bloating and constipation with the Ozempic?
So one of these GLP-1 agonists that we talked about previously is Ozempic, and one of the mechanisms of action, it actually slows down the motility or movement of the GI tract. So yes, very common side effects are bloating, early satiety, constipation with these medications. A lot of it's due to the underlying medication. One thing that may be able to help in this patient is make sure they don't have an underlying issue already. Do they have baseline constipation, which is untreated? Do they have gastroparesis prior to starting this medication that has been exacerbated by this medication? So there may be some other underlying issues that may have been overly exacerbated by addition of this medication.
All right. Another question, a viewer from Custer said they had a colonoscopy in the past. How do you restore your gut health after a colonoscopy?
They probably don't have to do anything. And the main thing that would disrupt gut health is the use of antibiotics. And that's what we're seeing now is, use of antibiotics for common cold. Dr. Kruse, you've seen patients in the office with that. Yes. And, patients will want an antibiotic for that. And it's important that we use those antibiotics judiciously and carefully, because that's what will disrupt gut health, certainly more than a colonoscopy. A colonoscopy alone, if you just, within a few days, the microbiome or the gut bacteria will reproliferate, and they don't have to worry about it. And I wouldn't recommend a probiotic because that's really fallen out of favor in gastroenterology right now. We had mentioned it earlier in talking to the students that probiotics are now not even recommended by the major GI organizations.
Okay, good, because a viewer was actually just asking, do you recommend taking a probiotic and which one?
Yeah, so my vote on that would be, I don't think I would do it.
Okay. All right. Well, another viewer says, do fruits and vegetables require different digestive enzymes? This sounds like a board question. I don't know.
For the most part, all of our food's broken down in our stomach with the low stomach acid that we have. Typically people tolerate fruits and vegetables for the most part. Some people may, with certain fruits or vegetables, may have some bloating, and that's why one of our most popular GI diets, a FODMAP diet, may come into play with some of these fruits and vegetables. But generally speaking, digestion of fruits and vegetables should not be any different than other things, and they're well tolerated by our GI tract.
Excellent. Well, another dietary intake people are asking about, what does drinking a 6-pack of soda do to your digestive system? I'm one of those that does that, actually.
And so I think, the one thing that you have to be worried about is the development of osteoporosis in those individuals. And but in terms of a 6-pack of soda, that seems like a fair amount to me. There's a fair amount of caffeine there if it does contain caffeine. If they're having reflux problems, you'd certainly want to avoid that, and you'd certainly want to avoid drinking those beverages later in the day or before bedtime, because that will predispose to reflux. So I think that's the main concern that I have with those. But in terms of health maintenance, it's been associated with osteoporosis.
Okay. I know our dietitians would have lots to jump in with this about the nutritional value of 6 sodas a day with the calories and sugars involved,
Sure.
but not much with the gut as far as.
Well, I think, if we're talking about diet soda, then that's a different situation. Regular soda contains fructose. And fructose we know is a magnifier in the colon for growing colon polyps. In fact, it's a risk factor for growing colon polyps. So if this is regular soda, absolutely, that's way too much fructose syrup.
All right, excellent. Another viewer says, they have stomach pain every day and gas. No doctor has been able to figure out what's causing it. What should they do? Sounds like they need to make an appointment with one of you.
I would say that's a good place to start. Probably start with your primary care, get an initial evaluation. Stomach pain, the differential diagnosis is vast. There's people who come in with stomach pain to the GI clinic and it's not your stomach. It might be a blood vessel in your abdomen, might be your kidneys, might be your spine and you have a referred pain. So the possibilities are endless of what could cause just generalized abdominal pain. So I would suggest that patient seeks medical care to get a better semblance of that. And if they've followed up with their primary care and still have not found that answer, gastroenterology would be a next good step.
All right. A viewer is asking about pantoprazole. That's one of those PPIs. Asking, is that hard on the stomach?
Probably not. Now, there are about 6 or 7 drugs in that drug class called proton pump inhibitors. Pantoprazole, or the brand name was Protonix, but it's generic now, is actually one of the weaker ones, believe it or not. And so patients that are on pantoprazole once daily or even twice daily, if they have severe reflux and they have to take it before breakfast and before supper, it's probably not hard on the stomach. One frequent thing that we see as gastroenterologists when they're on that drug class is we see the development of small polyps in the stomach. We call those fundic polyps. They're really of no consequence and they don't predispose to stomach cancer. The one thing I would say about pantoprazole, and in terms of that entire drug class, is that medication has to be taken a half an hour to an hour before the meal to be effective. If they take it after the meal, it simply is not, it's not going to work. It's not going to be efficacious.
Yeah. Can you kind of explain how these proton pump inhibitors work?
And so proton pump inhibitors, again, as Jeff mentioned, you have to take them on an empty stomach. They're absorbed from your small bowel, and they actually stop the acid from entering your stomach by working on a proton pump inhibitor in the gastric wall lining, basically increasing the pH in your stomach.
Okay, so those medications prevent those proton pumps from opening, but once they're already open after you've eaten, you're not going to close them back up.
It won't be absorbed because it won't be able to shut the acid off. And so, in fact, that's one of the most common things that we teach, that Dr. Lapp and I teach the medical students, is make sure you ask the patient if they're taking that medication the way they should be taking it. And at least 30% of the time you find out that they're not. And that's an easy fix.
All right. Another viewer says they had a colonoscopy and they removed some polyps. How do they form and why do they need to take them out?
Colon polyps, that's a big topic. And we're seeing individuals now that have larger colon polyps than when I trained. And we chatted about it earlier. Colon cancer now is the #1 cancer in men under the age of 50. And those are from colon polyps. All colon cancer comes from a colon polyp. The type of polyp that was removed is going to be the key answer to this question. If these were precancerous polyps, then they need to have a follow-up colonoscopy. And the guidelines on that have changed. It used to be that we need to bring them back sooner. Now the guidelines are that we can give them a little bit more time in between a follow-up colonoscopy from the index colonoscopy, but colon polyps are quite common, and there's so many risk factors for that. Body weight, smoking, hereditary causes are important. Microbiome is going to be something to think about in the future for development of colon polyps and colon cancer. That's a very broad topic.
Yes. All right. Well, another viewer says, when you have a hernia, is it always best to have it repaired surgically, or is it best to have it treated medically? Now, I'm thinking, which hernia? There's several different.
I'm guessing in relation to the GI tract, a hiatal hernia is probably one of the more common ones that we see. They are exceedingly common, whether you have an X-ray, a CAT scan, or a camera scope into your stomach. Not all of them need to be treated or surgically repaired. They may be a contributor to acid reflux, and as we've spoken to earlier, these acid reducers such as proton pump inhibitors may be able to manage it if that's a contributing factor. Rarely they need to be repaired if they're causing bleeding, they're having occurring ulcers, they're causing pain or obstruction, then those are definitive reasons to get that repaired.
All right. Can you tell our viewers what is a hiatal hernia?
And so a hiatal hernia is when first part of the stomach is in the chest. So it should be below the diaphragm. And that diaphragm sits where the esophagus and stomach connect, acting as a barrier to acid reflux. And sometimes as people age, that stomach can migrate into the chest. You lose a barrier to acid reflux and may expose you to a risk factor for acid reflux.
All right. Well, the next viewer from Madison says, what causes diverticulitis and what causes it to flare up? How long to recover after taking medications?
You know, diverticulitis is an evolving situation in gastroenterology. We used to routinely use antibiotics to treat diverticulitis. There have been some recent guidelines now that have said that doesn't necessarily have to happen. When we do colonoscopies, we oftentimes will see pockets in the colon or outpouchings in the colon. That's diverticulosis. Diverticulitis is actually an inflammation of those pockets, and if it's just simple diverticulitis that is not associated with a perforation where there's actually an abruption in the wall of the colon from diverticulitis, most of the time those episodes don't require antibiotics and will resolve on their own. We know that constipation will predispose to diverticulitis. So if you can kind of correct that, we also know that there was several studies that have confirmed this, that there's really no need to avoid seeds, nuts, popcorn, the diet doesn't matter in terms of recurrent episodes of diverticulitis. If a person has diverticulitis that's recurring, then they may need to have that section of their colon removed so that they don't acquire an abscess or acquire a perforation.
Well, that's a huge relief for a lot of patients who were told no nuts, no popcorn, no seeds, no anything, no strawberries. Had people say, "Oh, I can't eat those. I have diverticulosis." Yeah. So
we still see that. We still hear that all the time, that they've been avoiding those items in their diet, and there's just no data to support that.
All right. Well, very good for our viewers to know that. Well, what we eat significantly impacts our well-being. Marnie Shoemaker, an assistant professor at South Dakota State University and a registered dietitian, discussed the low FODMAP diet with Prairie Doc, highlighting how restricting specific carbohydrates can benefit certain health conditions.
So the FODMAP diet is an acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So a lot of different sources of carbohydrates that basically are hard for people to digest. They pull in a lot of water into the small intestine, and fermentable gut bacteria respond quickly, which lead to a lot of digestive symptoms.
Shoemaker says those who should try the diet are individuals experiencing symptoms related to irritable bowel syndrome or other undiagnosed digestive issues.
So a lot of bloating, gas, changes in bowel habits, and other gastrointestinal diseases, so like inflammatory bowel disease, ulcerative colitis, Crohn's disease.
She says the low FODMAP diet is a short-term solution.
The reason why it can help reduce symptoms is a way to eliminate high FODMAP sources of foods in the diet with instruction through an RD, a registered dietitian, to pinpoint kind of what foods exactly are causing some of these symptoms in the individual. And so by eliminating them, then slowly reintroducing and tracking symptoms, it can be more likely that they'll be able to find out what and how much of these certain foods are causing said symptoms.
Shoemaker emphasizes the importance of working with a registered dietitian when implementing this diet, noting how it is highly individualized.
It's very individualized, and I can't emphasize that enough. It's like, it can be a great thing. It could be the best thing in the world for someone who's experiencing these disorders, but you have to be able to do it right, because eliminating that many foods and that many food groups can be not only tough for a person to do, but just, it could be really detrimental.
Well, what other diets, such as the FODMAP diet, can help individuals with gastrointestinal issues?
Well, you know, I think there's a large focus on gluten sensitivity right now. And we certainly do see patients that have celiac disease, that have, you know, an issue with gluten, but the majority of the patients that we see that think they have a problem with gluten actually have something called gluten sensitivity, where they bloat from eating gluten. They know exactly when they eat gluten. And you know what? It's a spectrum. And so you can go from florid celiac disease to a gluten sensitivity with identical symptoms. It would take an upper endoscopy with biopsies of the small intestine to differentiate that, because in celiac disease you see the specific changes in the lining of the duodenum that would lead you to the diagnosis of celiac disease. But if patients have a sensitivity to gluten, by all means, avoid it. Absolutely. I think that's the most common thing that we see.
And it's gotten much easier as there's been more information about celiac. I mean, you can find more foods that are available in more restaurants and businesses catering to that compared to even 5-10 years ago.
Absolutely. So grocery stores, oftentimes Hy-Vee specifically has a dietitian that works there that can help patients that have a gluten sensitivity issue, and they have items that are gluten-free. It's very hard to eat outside the home and maintain a gluten-free diet. It's almost impossible because of cross-contamination. So eating at a restaurant and trying to maintain a gluten-free situation, that's challenging. But if you can eat at home, and if you get the help of a dietitian, whether it's in the office or where you buy food, your groceries, that's very doable.
Excellent. Well, another viewer is asking your opinions about fecal transplants and when to use them. Have they been performed in the U.S.? Yes, I've done them.
There you go. Yes, you've answered the question. And so I think the most common reason for a fecal transplant in GI is probably a recurrent C. diff infection or a persistent C. diff infection, which is Clostridium difficile. And that is an infection in our colon that causes profuse watery diarrhea. Lots of times antibiotics will treat that. However, antibiotics are the leading source of getting C. diff. So when those fail to work, then fecal transplant may be a rescue therapy for those patients.
Yes. And it's come a long way from when I did my very first one as a third-year medical student and had the honor of processing the sample to give to the patient. Now it goes through basically a corporation, and they have specific donors that are tested, and they basically package the donation in a very sterile, safe way while keeping that good bacteria alive, but does not involve an intern with a tongue depressor and some sterile water.
Oh, wow. Yes.
Yes, it's come a long way, but incredibly effective.
It can be the last resort before taking your colon out or doing a colectomy in some of these, end-stage infections. So yes, it can be life-saving.
All right. Another viewer says, as they have aged, they've lost some of the sense to defecate. Is that normal?
It can be. And there are certain tests that we can do. Certainly, I'm hopeful that this patient's had at least a colonoscopy to make sure that there's not something anatomically or structurally wrong with the colon, because you want to make sure that they don't have a colon polyp or even worse in the colon. Hopefully, they've seen a gastroenterologist or their primary care doctor and had a rectal exam, and just made sure that there's nothing there that's structurally involving that area. But as people get older, they lose the sensitivity to defecation. In fact, that's, again, as we touched on it before, that's one of the main reasons why you'd want to avoid banding hemorrhoids in an elderly individual, because it could make that situation drastically worse.
All right. Well, another viewer says they were recently diagnosed with Crohn's disease. What is the long-term care going to look like for that?
So Crohn's disease is a common disorder that we see in our clinic, and it's one of our chronic disorders that we follow patients longitudinally. And so this is a lifelong disorder of inflammation of your GI tract. Anywhere from your mouth to your anus, you can become inflamed. More commonly in the colon and small bowel, may result in abdominal discomfort, bowel obstruction, bleeding, change in bowel habits. So I think the essential thing when you carry a diagnosis of Crohn's disease, you do need a GI doctor. You will see them frequently. You will have discussions about chronic long-term medications to try and control that inflammation. There's lots of other things that we need to do, make sure they're up to date on their immunizations, make sure they have a good primary care following along, because this is somewhat of a complex disorder. We're learning more and more about it. There's more medications to treat it, but I think it boils down to that a gastroenterologist needs to be involved in their care.
Excellent. Another viewer is asking, what's the difference between IBD and IBS?
Black and white. IBD is inflammatory bowel disease. That's what Dr. Lapp was talking about with Crohn's disease. IBD also encompasses ulcerative colitis. And those are inflammatory conditions of the colon, and in the case of Crohn's disease can involve the small intestine and other areas as well. IBS is irritable bowel syndrome. Those are individuals that oftentimes will have bowel habit changes, either more constipation, more diarrhea, some abdominal bloating. Oftentimes they'll have relief of their symptoms either with defecation. They may fill up fast when they eat, a term that we call early satiety. They're very different, and the medications in those entities are very different. Inflammatory bowel disease, when I was in training, we had maybe 1 or 2 medications, and now we have over 20 that are available for use in inflammatory bowel disease. Irritable bowel syndrome is a completely different entity, but if they have irritable bowel syndrome, the patient should be reassured that it's probably not going to be life-threatening. It's probably not going to lead to any kind of a chronic inflammatory condition. It may bother them throughout their life, and there's probably things that we can do to alleviate some of those symptoms, but inflammatory bowel disease is a completely different entity.
All right. Well, another viewer is saying, can I just use the Cologuard instead of a colonoscopy?
So I would say any screening is better than no screening. A Cologuard's a more convenient at-home test. It's very good for screening for colon cancer. It does not hold the same weight as screening for colon polyps, which are the precursor to a colon cancer. So yes, it does help in colon cancer screening. Yes, I think it is a good adjunct to screening. A colonoscopy's gold standard, but yes, any screening is better than no screening. I think the only difference is it's not as good at finding those precancerous lesions compared to a colonoscopy.
All right. I always tell people that if the Cologuard's positive, you're going to need the colonoscopy.
Yes.
And the colonoscopy is the only screening test I know of that can remove precancers and prevent a cancer from happening in the future. So,
absolutely. Yes.
Yes, I had mine when they lowered the recommendation down to 45. I did it because it's so important. And we're seeing, you were talking earlier how the ages for colon cancer is really lowering.
The age for colon cancer is definitely lowering, and the thing that the public needs to be aware of is that even though colon cancer is the #1 cancer in men under the age of 50, and the screening starts at age 45, over half of those colon cancers are found before the age of 45, where the patient wouldn't have been screened. So this is a very complex algorithm that we're involved with right now, and there's even some talk now of even lowering the screening age even further. I think that needs a little more traction. But we clearly are just touching the tip of the iceberg on this.
All right. Well, I would say, what would be symptoms that patients should be looking for that would make them concerned about colon cancer?
Change in bowel habits, blood in my stool, potentially abdominal pain, unintentional weight loss. Other things outside of specific symptoms are, do I have a family history? Is another big one that may drive them to do colon cancer screening.
Excellent. All right. Well, another viewer is asking, how does coffee, alcohol, and smoking affect gut health?
We can talk about all three.
Yeah.
Coffee, you know, I don't have too much of an issue with coffee or caffeine. I mean, I'm assuming if they want to drink a cup or two in the morning, I don't really have problems with that. Alcohol's a serious situation, and there is an entity out there called alcohol use disorder, AUD, and we're seeing that as a very common form of chronic liver disease right now. And we're even seeing that even moderate doses of alcohol can lead to a form of chronic liver disease, especially in individuals who are overweight, and especially in women. And we don't necessarily understand all of that. It's linked to something called increased fat in the liver. We have a name for that. It's called hepatic steatosis. And those, or now it's called MASH, and those are individuals that are at high risk for developing cirrhosis. And smoking, smoking predisposes to colon polyps. And I think that's in addition to all of the other health problems with smoking, pulmonary disease, lung disease, emphysema, bronchitis, heart disease. Smoking just kind of permeates every aspect of our health. But in terms of gastroenterology, we know that smoking is a huge risk factor for developing colon polyps and colon cancer.
All right. So if you needed another reason to stop smoking, your colon health as well.
Absolutely.
Add it to the list. All right. Well, another viewer says, can proton beam radiation treatment after prostate cancer damage the rectum?
So this is a condition called radiation proctitis that we can see after treatment of prostate cancer with radiation. So yes, the rectum can be an innocent bystander when you're undergoing prostate cancer treatment. Typically that presents as blood in the stool, typically painless. There are some treatments we can do through colonoscope that may be able to stop the bleeding or make it less frequent. So yes, we see this frequently in these individuals.
Okay. Another viewer is asking about prebiotics versus probiotics. What do they do? What are the functions? Are they helpful?
We touched on this a little bit earlier, and I think the data on prebiotics and prebiotics are substances that enhance the bacteria's ability to proliferate in the colon. We know that we have over 1 trillion types of bacteria in our colon, and probiotics are introducing bacteria to the gut. And I don't really see, I haven't seen a study in a long time that supports the use of prebiotics or probiotics. In fact, you can see it's actually to the contrary, where you see some individuals taking a probiotic and proliferating their gut with bacteria that may not be the ones that they should have in their gut to begin with. And so you're better off just really not focusing on that. If they're having symptoms and they think they want to treat those with a prebiotic or a probiotic, their best situation is to discuss it with their primary care physician and possibly even discuss it with a gastroenterologist.
All right. Well, just a few minutes left here, so we'll see if we can get these last few questions done. A viewer said they had H. pylori in the past and wondering if they should get rechecked after treatment to make sure that it's cured.
Oh, great question. So H. pylori, as Dr. Murray mentioned, is becoming more common in our general practice, but it's an infection in the stomach that may lead to stomach ulcers, typically eradicated with antibiotics and acid reducers, but that eradication testing is essential to make sure the bacteria is gone, as it may be precancerous in nature and lead to stomach cancer down the road. Typically, we recommend testing about 8 weeks after your treatment is complete. Some of the essential things when you do treatment testing for eradication is you're off your acid reducers and you're off your antibiotics for about 2 weeks before, to make sure you don't have a false negative test. And typically the testing that we do is a stool-based test to follow up that H. pylori infection and prove it's eradicated.
All right, well, about a minute left. This interesting question. A viewer says after drinking water, they end up having chest pain that radiates to their ears. What could it possibly be?
You know, it could be a lot of things. If it's cold water, it could predispose to something called esophageal spasm, or just any kind of swallowing can predispose to esophageal spasm, and that pain can definitely radiate up to the neck and even to any place in the head and neck. And esophageal spasm we see quite a bit. It's diagnosed a couple of different ways. They would need an upper endoscopy, number one, to be sure there's nothing structural going on there. The other test that they would for sure need is a high-resolution esophageal manometry. We'll measure the motility of the esophagus, where we can actually solidify the diagnosis and prove that they have esophageal spasm. Sometimes that needs to be coupled with a barium study to see if there's esophageal spasm as well. We can see corkscrewing of the esophagus, or we can see something that looks like a rosary bead, literally. And it's treatable medically. It's treatable medically. It's also treated surgically. But that's a real symptom.
Okay, excellent. Well, I had one episode of that as a medical student after I drank a cold slushy, and I was convinced I was having a heart attack. So they can be very painful. So I'm glad the viewer asked that. Well, our winner tonight is Marcia. A book will be sent to you shortly. We'll be back after this.
Hi, my name is Preston Holm. I serve on the Healing Words Foundation Board, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Don't miss out on the latest insights into health and wellness. Be sure to pick up a copy of your local newspaper or explore the Prairie Doc Perspective online, a weekly column dedicated to providing valuable information on health and medical topics. Access all previously published columns and stay informed by visiting www.prairiedoc.org.
As we finish up this evening discussion, I want to thank Dr. Lapp and Dr. Murray for sharing their expertise with our viewers. And thank you to all of our viewers for tuning in tonight. We appreciate your continued viewership and support. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight, or it didn't align with our topic, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on SDPB Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions: Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,